Our moderator will be, inshallah, Dr. Maher. Dr. Maher is Chief of Anesthesia Department at Al-Ulayya, Dr. Sulaiman Habib Hospital. He will present the speakers for you, and he will moderate the session.
Assalamu alaikum. Welcome to our fourth session, which will be about expert insights in enhancing patient outcomes with the latest advances. Our first speaker is Dr. Mahmoud Al-Mustafa. He's a consultant anesthesiologist at King Faisal Specialist Hospital and Research Center. He also serves as a professor of anesthesia at the Faculty of Medicine, University of Jordan.
Thank you very much, Dr. Maher. And I want to thank Habib Medical Group for their invitation to attend and to present my talk in this prestigious conference. So my talk today is about dexmedetomidine and neuraxial block. The pronunciation of dexmedetomidine is difficult, so I will say dex. Sorry for that. So many medication used as adjuvant with local anesthesia and spinal anesthesia. Just to declare that I have no financial disclosure or conflict of interest with my presentation material. Dexmedetomidine, as we know, is an alpha-2 agonist. Was initially approved by the FDA in 1999 for the sedation of intubated patients in critically care setting for less than 24 hours. Do we have microphone? Mic to move. Okay, no problem. As I mentioned, many medication used as adjuvant, such as epinephrine, phenylephrine, adenosine, magnesium, clonidine, which is also as alpha-2 agonist. All of these, the main aim of usage was to prolong the duration of spinal anesthesia. The first time the dex used was in 2006 by Dr. Kanazi in the American University of Beirut. Thank you. So Dr. Kanazi used the dexmedetomidine in the intrathecal route in 2006, and he published his research in the Anesthesiology Scandinavian Journal, Acta Anesthesiology. And in this research, he used the clonidine and the dex to compare this with the bupivacaine group alone. He used a 3 microgram of dex and used a 30 microgram of clonidine added to the bupivacaine, and there is a control group where the bupivacaine is used alone. And in this study, he concluded that the supplementation of bupivacaine with low dose of intrathecal dex or clonidine significantly shorter the onset of motor block and significantly longer the sensory and motor block than bupivacaine once it is used alone. If we look for this study, the B group is the bupivacaine, the C is the clonidine, and the D is the dex. He studied the sensory regression to 2 dermatomes, sensory regression to S1 segment, and regression to the PROMET score 0. What is the PROMET score? If we look for this slide, PROMET score 0 means the patient is able to move hip, knee, and ankle. Full power. 1 patient is unable to move hip, but able to move the knee and the ankle. 2 patients is unable to move hip and knee, but able to move the ankle. And 3 patients is unable to move hip, knee, and ankle, fully paralyzed. So in his study, if we look for the numbers or the minutes, the sensory regression to 2 dermatome, for example, it was 80 minutes in the bupivacaine group, and in clonidine 101 minutes, and in dex it was 122 minutes. And it was highly significant, the p-value was significant. Also the sensory regression to S1 segment and regression to PROMET 0. I conducted my own study in 2009. This paper published in the Saudi Medical Journal. I used different doses of dex. In this study, the patients were divided to three groups. The dose of isobaric 0.5% bupivacaine, it was a standard 12.5 milligram, which equal to 2.5 milliliter. And we added to this either normal saline or dex 5 microgram or dex 10 microgram. The total volume in all patients was 3 ml per dose for spinal anesthesia, and it was a blinded study. The comparison between the groups regarding the demographic and surgical characteristics of this study, all the age, gender, BMI, ASA, and the surgery type were comparable, and it was not significant. There was no differences. We study in this study sensory block to reach T10 dermatome, motor block to reach Promeg 3, and sensory regression to S1 segment, and motor block regression to Promeg 0 to come back with full motor power. So again, surgical characteristics and adverse event during the procedure regarding the IV fluid, the duration of surgery, the blood transfusion, additive analgesia, nausea, vomiting, bradycardia, and hypotension, usage of atropine or ephedrine was not significant in all three groups. So why we look for the bradycardia, hypotension, atropine, and ephedrine? And because, as we know, the side effect of dex is hypotension and bradycardia. But with these doses, it was not significant. During the procedure, we look for the vital signs: heart rate, mean arterial pressure, intra-op and in the post-op in recovery. Also, it was not significant, either the heart rate or the mean arterial pressure. Also, in the recovery room, we observe our patient for 1 hour, and also it was not significant. In conclusion, our study of dex precipitated the onset of sensory and motor block, and it prolonged the sensory and motor block significantly when used with bupivacaine in spinal anesthesia in a dose-dependent manner, because we used a 5 microgram and 10 microgram. So it was clear that when we increase the dose to 10 microgram, the duration of a block will be more at that time, and the minutes will be more and more. So what is the mechanism of action of adding intrathecal dex? How it works? The mechanism of action is not clear till now. It may be additive of synergic effect of secondary to the different mechanism of action of the local anesthetic and the alpha-2 adrenergic agonist. It may be an additive of or the local anesthetic act by blocking the sodium channel, as we know, whereas the alpha adrenergic agonist by binding to presynaptic C fiber and postsynaptic dorsal horn neurons. So the mechanism of action till now, it is not clear how it works. During my research and conducting this study, I face a problem about neurotoxicity. There was a paper from European Journal of Anesthesiology, which is published in May 2008. And the origin of this study was from Turkey, and they conclude in their study that dexmedetomidine does not have motor and sensory effect, but it may have a harmful effect on the myelin sheath when administered via the epidural route. So now there is a problem. Demyelination, so there is a harm on the nerves. So it might be risky to the patient to use this medication in the intrathecal route. Already I collected my data and I start to publish my paper that I mentioned before. Later on, many studies about this issue. For example, this study evaluation of the neurotoxicity of intrathecal dex on right spinal cord, electromicroscopic observation. They use the microscope to observe if there is any harm in the myelin sheath of the nerves. They found that there is no effect, and another study, dexmedetomidine does not compromise neuronal viability, synaptic connectivity, learning, and memory in the rodent model. So many studies, they found that there is no effect on the myelin or on the nerve, and there is no neuronal toxicity, as mentioned in the previous study. What is the optimal dose of intrathecal dex? For example, in this study in the lower abdominal surgery, there was a study regarding this issue. They used 5 groups: the D1, D2, 3, 4, and 5. In this group, they used the bupivacaine with saline, which is the control group. The D1, they use 5 microgram. D2, they use 10. D3, 15, and D4, 20 microgram. And they compare this group regarding the onset and the prolongation of spinal anesthesia, and later on they look for the side effect. They found that as we increase the dose of dex, the prolongation of spinal anesthesia will increase. But with the D3 and D4, which is the 15 and 20 microgram, they found that there is a hypotension. So they need to treat this hypotension with medication in those groups. So they conclude in this study that 5 to 10 microgram of dex added to spinal bupivacaine is the proper dose to be added to bupivacaine in spinal anesthesia. Right. What about intravenous dex and the duration of spinal anesthesia? Also, we have another study conducted in our hospital, in Jordan University Hospital. It is about intravenous dex prolonged the bupivacaine spinal anesthesia. Also, we had 2 groups. After spinal anesthesia, bupivacaine with 12.5 milligram. Patient in group B received intravenously a loading dose of dex, which is 1 mic per kilogram over 10 minutes, and maintained with 0.5 microgram per kilogram per hour. Patient in group C, which is the control, received normal saline infusion, and we calculate the regression time to reach S1 sensory level and the Bromid 0 motor scale, and we look for the hemodynamic changes and the level of sedation were recorded. If we look for the control group and the dex group, we found that when we use the dex group as IV, there is a prolongation in the motor block and in the sensory regression. It was significant. The p-value was highly significant. In this study also, demographic data was comparable. Hemodynamic, we noticed that the heart rate, it was not significant, but there is a decrease, the mean arterial pressure was not significant, but there was a significant decrease in the heart rate, as we see in the right side, in the lower right side, in the graph. The heart rate in the dex group were less than the control group. And regarding the sedation group, we used the Ramsey sedation score, and during the procedure, we achieve a good sedation for those patients, and it is good for the patient to be sedated, and the duration of surgery or the duration of spinal anesthesia is prolonged. What is the mechanism of action also of the dexmedetomidine once we use it in the intravenous route? Usually the dex affect the locus coeruleus, which is located in the brain stem. Locus coeruleus, usually it works during the panic attack or during stress to release the norepinephrine and epinephrine, to increase this. So the dexmedetomidine will affect the secretion of these hormones and it will decrease the stress response in this situation. So also how it works and it affects the spinal anesthesia, the mechanism of action is still not that clear for this effect. Other study also I was involved in it. It was in pediatric patient for caudal anesthesia. We used the dex added to the bupivacaine with a concentration of 1 microgram per kilogram added to the bupivacaine, or 2 microgram per kilogram added to the same dose of bupivacaine. And we have a control group. In this study, we found that the 2 microgram per kilogram, there is a side effect when we increase the dose. And they need to treat bradycardia and hypotension in certain cases. So the conclusion from this study that a 1 microgram per kilogram dose of caudal dex achieved a comparable prolongation of the post-operative analgesia to 2 microgram per kilogram dose, with a shorter duration of post-operative sedation and lower incidence of other side effects. So they conclude in this study that the best to use 1 microgram per kilogram in caudal anesthesia in pediatric patients. Even many pediatric anesthetists, they noticed also that sometimes even with this dose, 1 microgram per kilogram, it might affect the hemodynamic stability of the patient and might decrease the heart rate and decrease the blood pressure also, and might need intervention with medication. This also another study done by one of the medical students in University of Jordan. It was a meta-analysis in orthopedic surgery, the usage of dexmedetomidine as in spinal anesthesia. And in this study, we conclude also that dex was found to achieve extended motor and sensory block when needed, bearing in mind high cost and potential side effects. So these are the studies that I was involved in. And in summary, if we look for these studies, the take-home message that dexmedetomidine used widely in the intrathecal route, even it is not FDA approved. There is a lot of clinical trials, thousands of clinical trials done in this field, and it is safe and effective, but till now it is not FDA approved. The dose that to be added to the bupivacaine when we use, the ideal is 5 to 10 microgram. If we increase the dose, okay, we achieve more block for the sensory and motor, but we might face a problem of the side effect. In pediatric patient, we can use this in caudal anesthesia, but with the precaution to the side effect to treat the bradycardia and hypotension if it occurs. If we want sedation and prolongation of spinal anesthesia, the best is to use intravenous dex added to the spinal anesthesia, bupivacaine or whatever, and we found that it will provide sedation and the prolongation of sensory and motor block. And thank you very much.
Thank you, Dr. Mahmoud. Our next talk will be about paralytics in practice. It will be presented by Dr. Hussam Shara. Dr. Hussam is a consultant anesthesiologist. He holds extensive experience in general and regional anesthesia, and he was contributed to various anesthesia services across multiple departmental, including surgical, obstetric, intensive care units.
Good afternoon, everyone. Thanks for inviting me first to participate in this prestigious conference. I'm going to talk about paralytics in practice. If we are up to date, I'll try to update or debrief the updates from a clinical point of view. So the objectives of this presentation, proper anesthetic management for laparoscopic procedures, reducing the incidence of post-operative residual paralysis, and highlighting the current 2023 recommendations regarding indication of muscle relaxants, deep paralysis, and reversal of muscle relaxation. So, starting with the laparoscopy, we can see that the post-laparoscopic pain is a problem, and the contributors to this pain are many. From this image, you can see that lots of factors can contribute to the post-operative, post-laparoscopic pain. The traditional pain control in laparoscopy, multimodal analgesia, post-operative recovery and post-op pain orders as usual, local anesthetic infiltration usually performed by surgeons. That's a routine practice. If we have anything else to say, we need first to illustrate that what's happening during laparoscopy. Talking about splanchnic perfusion, there is increasing body of evidence that pneumoperitoneum decreases splanchnic perfusion, resulting in oxidative stress response. It's now appropriate to investigate the clinical significance of pneumoperitoneum-associated oxidative stress. And from this graph, you can see that the most affected organs by the pneumoperitoneum are the peritoneum itself. As you can see, 70% reduction in perfusion of the peritoneum, and the second would be the mesenteric arteries, nearly 65 up to 70% reduction in mesenteric perfusion. So perfusion is definitely compromised. Chronic lower abdominal pain, it definitely impairs the quality of life. And in a review study of about 11 studies, they showed that adhesions responsible for the chronic lower abdominal pain in only 40% of women undergone laparoscopic surgery. And the cause remained unclear, but in a prospective study, they observed significant reduction in chronic abdominal pain after right-sided paracoelic adhesolysis. And in contrast, other studies found no change in pain scoring after laparoscopic release of adhesions. So adhesions are not the main factor responsible for the post-op pain. So maybe 2 decades earlier, the concept of deep paralysis was raised by a group of researchers in Europe who studied that deeply. But first, by deep paralysis, we mean that the diaphragm is paralyzed. Patient can have a train of 4 of 0, yet not deep enough. Patient, to achieve that, you need to be guided by a neuromuscular monitoring with target of post-tetanic count 0 to 5 as maximum. This is a very useful tool to improve what we call the abdominal compliance during laparoscopy. Does deep neuromuscular block during laparoscopy procedures change the patient's surgical and healthcare resource outcomes? This is a systematic review and meta-analysis published in 2020, concluding deep neuromuscular block may aid in the patient and physician surgical experience by improving certain patient outcomes, such as postoperative pain, improved surgical rating. By that we mean the surgical workspace and how easy the surgeon is happy with the laparoscopic workspace to perform the procedure. That was when it compared to moderate neuromuscular block. So this showed that deep muscular block is beneficial. Before proceeding, I just need to illustrate what do we mean by deep block. As you can see from this simple graph, muscle paralysis, the degree of block can go from moderate block, which is identified here by a train of 4 count 1 to 3, deep block 0 train of 4, post-tetanic count up to 5, more 1 to 5. Then the intensive block where we don't get any train of 4, 0, and also 0 post-tetanic tetanic count. So the block could be either moderate, deep, or intense. The phenomenon of residual colorization is another point we need to illustrate today. Post-operative residual colorization is a big issue for patient safety. Global underestimation of the residual block. A survey conducted long ago, about 18 years ago by Professor Naguib, conducted in Europe and the US, showed that the lack of knowledge and consideration of residual block phenomena, and the majority of respondents, after a questionnaire was distributed, claimed that the incidence is very low from the anesthesiologist's point of view. They claim it's maybe less than 1%. But only 10% of the American anesthetists at that stage, 33% of the European, considered it necessary to monitor muscle relaxant using, by monitoring I mean a quantitative monitoring, using neuromuscular monitoring. So post-operative residual colorization is identified by instrumental signs, which means by applying the neuromuscular monitor, which shows a train of 4 less than 0.9 or less than 90% by the end of procedure after recovering the patient. The muscles involved in swallowing, such as tongue, pharynx, get decolorized with more difficulty and are therefore implicated in this phenomenon. Also, reduction in cough reflex and reduced expansion of the rib cage with superficial ventilation, inadequate and decreased chance of tracheobronchial secretions. Clearance of secretions is inadequate. The criteria which is more often decided to decolorize are the time elapsed, how the anesthetist decided that he needs to reverse. Usually, clinically, the decision was made by how long time elapsed between the last dose of a neuromuscular blocking agent given and awakening. Also, taking the total dose of relaxant given into consideration, and some subjective clinical parameters indicative of residual weakness. Only 45% of anesthetists in Europe, 12% in the United States base the decision on using train of 4. Surveys from Germany and France and United States have suggested that only a minority of clinicians routinely reverse neuromuscular blockade at the end of anesthetics. Despite extensive documentation of such residual paralysis in the literature, the awareness of the clinical consequence remains very limited. The use of non-depolarizing muscle relaxant and the neuromuscular monitoring and reversal agents is dictated by tradition and local practice rather than by evidence-based medicine. So we need to monitor the patient. Do we really need to monitor? I think if you think home that if you're using muscle relaxant and you have the monitor available, please put it in. So why do we need to monitor? To improve patient safety, to analyze the onset, duration, and recovery index, to manage the medication better way, to establish the right time for reversal, the right time to extubate, to manage particular patient by increasing their safety, to reduce the incidence of post-operative respiratory complication, to find the degree of block, so improve surgical experience, to collect data about the neuromuscular blocking agents and antagonists. Why train of 4 more than 0.9 is important to memorize? Impaired inspiratory flow and partial upper airway obstruction have been observed frequently at train of 4 ratios of 0.8. So the gold standard for the minimal accepted level of neuromuscular recovery is train of 4 ratio of 0.9. The clinical tests are not substitute for objective monitoring. Reasons behind anesthesiologists' reluctancy towards deep paralysis. Why anesthetists don't want to give high dose of muscle relaxants to get the muscles into a deep paralysis? Number 1, fear of residual block. Lack of knowledge about the surgeon requirement or the surgical workspace required. Avoid unnecessary delayed recovery. Lack of routine usage of monitoring. Barriers to use prompt reversals. So muscle paralysis should not be taken lightly. We need to optimize surgical workspace, and we need to achieve these goals mentioned before with better understanding of the requirements. Here is the observational study that was published 6-7 years ago about post-anesthetic pulmonary complication after using muscle relaxants. It's called popular observational study. From this we can see that here you can see that the main bulk, more than 50%, they don't use neuromuscular monitoring. Here, about 75% of cases, extubation was based only on clinical criteria. And in the lower one here, we can see that reversal agents are used only in 51% of cases. That's observation study, the popular study, which reviewed nearly 20,000 patients. So that's how the practice is going on in US and Europe. Last part of my presentation will be about the current guidelines, or the current American Society of Anesthesiologists practice guidelines for monitoring and antagonism of neuromuscular blockade. This is a report by the American Society of Anesthesiologists Task Force on neuromuscular blockers. That was in 2023. That's a very recent one. So these are the summary of the recommendations and the grade of recommendation. We can see here the use of muscle relaxants to facilitate tracheal intubation is recommended as grade 1A, highly recommended. Use of muscle relaxants to reduce the laryngeal or pharyngeal injury is also 1C, which is a good recommendation. Use of fast-acting muscle relaxant like Sux or Rocronium at a proper dosage is highly recommended, and this is 1B recommendation grade. Deep blockage, if the surgical condition needs to be improved, is also highly recommended. There is no sufficient evidence to promote using deep block in general to reduce postoperative pain. Though beneficial, but there is no good evidence to support the deep block link to reduction in postoperative pain. Ulnar nerve stimulation and quantitative monitoring at the adductor pollicis muscle to exclude residual paralysis is 1B, which is high recommendation. Sugammadex to antagonize deep, moderate, and shallow block induced by Rocronium or Vicuronium is 1A recommendation, which is a very highly recommended dose. Treno4, more than 0.2, before starting new stigmine reversal and continue quantitative monitoring is 1C recommendation. Still highly recommended. Now we'll go into more elaboration about the recommendations. Here you can see the use of muscle relaxants is necessary to facilitate tracheal intubation. As you can see in this graph that 1,400 patients received muscle relaxants for intubation. You can see that 1,364 patients who did not receive muscle relaxants have got poor intubation conditions. So definitely, we need paralysis to facilitate tracheal intubation. So this is, as we said, recommendation grade 1A. Use of relaxant to decrease damage or injury to the pharynx or larynx is also, as you can see, highly recommended. Rapid-acting muscle relaxant like Sux or Rocronium for rapid sequence induction is highly recommended, 1B, but just to remind you that we need to use the Rocronium at a dose 0.9 to 1.2, high dose, milligram per kilo, if we are after rapid sequence induction. Does the intensity of block affect the outcome in abdominal surgery? You can see that deep neuromuscular block it can improve the outcome. Recommendation grade 1B. There is insufficient evidence to link the depth of the blockade to the postoperative pain. Ulnar nerve stimulation is recommended to be the source of monitoring for neuromuscular block. It is grade 1B. Now, what are the comparative effects of clinical assessment? Qualitative monitoring, like most of us used to do, and the quantitative monitoring using 3:4 ratio on residual neuromuscular blockade, pulmonary complication, and other adverse events. The body of evidence includes 16 studies, 10 randomized control, and 6 other trials, comparing the effects of quantitative monitoring with qualitative monitoring. And from that you can see that the recommendation when using neuromuscular blocking drugs, we recommend against the clinical assessment alone to avoid residual block. So clinical assessment without the use of neuromuscular monitoring is not recommended if you are to avoid blocks. Well, just to highlight, residual block is a problem that you might not observe in early post-operative period or even in recovery. But it is observed by lots of other things if we monitor it. Patient long stay in hospital, post-op respiratory complications, pneumonia, respiratory failure as well, are all linked to the residual block. So the patient will recover well in the OR, will not misbehave in recovery, but on the long term, you will see complications. Areas of collapse in the lung, increase the chance of pneumonia, length of hospital stay, and all that comes in. So that's a problem of residual block. That's why it was overlooked by anesthetists over years and years. What are the strategies for the diagnosis and treatment of residual block? Here we can say that the American Society of Anesthesiologists say that Sugammadex to antagonize deep, moderate, or shallow neuromuscular block induced by rocronium is highly recommended as grade 1A compared to neostigmine. What are the, to attain train of 4 more than 0.2 spontaneous recovery before starting the reversal using neostigmine and continue quantitative monitoring until train of 4 reaches more than 0.9. This is a recommendation of, highly recommended also 1C grade of recommendation. Finally, this is a clinical practice statements. The current evidence does not allow recommendation of one reversal agent over another. When reversing a train of 4 ratio between 0.4 and 0.9, the choice between Sugammadex and the neostigmine must take into account patient-related factors and availability. The second clinical practice statement is the recovery from SUX-induced neuromuscular blockade should also be monitored in a quantitative manner. Conclusion, there is convincing evidence that residual paralysis and relaxation-associated pulmonary complications are less common after Sugammadex-based reversal than after neostigmine. Reliable quantitative neuromuscular monitoring is the principal prerequisite of any appropriate strategy for perioperative neuromuscular management, whether it is spontaneous recovery, Sugammadex-based recovery, or neostigmine-based recovery. This is what we call the stronger trial, and here they compare Sugammadex versus neostigmine reversal for neuromuscular blockade after general anesthetics and the post-operative pulmonary complication in 12 US hospitals at 1-to-1 match, equal number of patients. 45,000 cases for matching, 22,000 for Sugammadex group and 22,000 for neostigmine group. Sugammadex was associated with 30% risk reduction for composite pulmonary complication, 47% for pneumonia, and 55% reduction in respiratory failure compared to neostigmine. So it's a very high evidence showing that the use of Sugammadex definitely reduces the post-op respiratory complication. This is a supplementary trial which is called Still Stronger, multicentric retrospective also cohort study. And the primary outcome shows composite post-operative pulmonary complication are reduced when we use Sugammadex rather than neostigmine as well. That's the results of the Still trial. So take-home message: deep relaxation might improve post-operative outcome. Avoiding residual block seems mandatory to reduce post-operative risks. neuromuscular monitoring needs to be used and guide our usage of muscle relaxants. Sogamadex is by far more superior to neostigmine in terms of complication reduction and efficacy. Thank you.
Thank you so much for this informative talk. Our next talk will be about regional anesthesia and anticoagulation. And let us welcome Dr. Mona Haqqi from Lebanon. She's a consultant anesthesiologist at Dr. Sulaiman Al-Habib Hospital, Takhasusi branch. She holds a diploma of anesthesiology from American University of Beirut and diploma in chronic pain management from Gulf Medical University.
Good evening, everyone. Today we will dive into most critical areas in regional anesthesia, which is the use of anticoagulation. The use of the intersection of bleeding risk and the patient safety. We will explore the 2025 ASRA recommendation and guidelines and what they mean to our daily practice. So the American Society of Regional Anesthesia and Pain Medicine released its 5th edition on the January 31st, 2025. These guidelines address how we manage patients on antithrombotic or thrombolytic therapy and who are undergoing regional anesthesia. History. ASRA has built decades of evolving recommendation, starting in 1998 and 2003 edition, which focus on neuraxial block in anticoagulated surgical patients. While the 2010 publication addresses for the first time the risk of significant bleeding associated with the blocks, plexus and peripheral. 2010 publication addresses for the first time the risk of significant bleeding in patients undergoing plexus and peripheral technique. The 4th edition in 2018 focused on the first time in risk of bleeding in parturients and in interventional and the patient undergoing interventional pain procedure. While today in the 2025, the American Society of Regional Anesthesia focus on the bleeding associated. It comes with more practical and personalized guidelines for every patient risk factor associated with the regional anesthesia and who are already on anticoagulation. What's new in this in the new guidelines? One major update in the guidelines is that we are moved from in the terminology from calling the anticoagulant doses as prophylactic or therapeutic into a new version, the low doses and high doses. Why? Because low doses in some patients may act as a high dose in another patient, depending on renal function, age, gender, and the drug interaction. Another new issue in the 2025 guidelines is the use of a drug-specific assay to manage the patient who is going to undergo the regional anesthesia and the neuraxial block. These assays are the anti-factor 10 level and the thrombin time and the specific plasma level of direct oral anticoagulant. We will explain this later. So why it is important to discuss the issue of regional anesthesia and central neuraxial block with in the patient who is undergoing thrombolytic or antithrombosis medication. Let's know that more than 6 million Americans are managed with a chronic anticoagulation. 20% of these will go under invasive procedure each year. So there is a risk of bleeding. This is a major issue. What happened during spinal anesthesia or epidural anesthesia. Hemorrhagic complication may occur after every neuraxial or peripheral plexus block. And this is very dangerous because when bleeding occurs within a fixed, non-compressible and or concealed sites as the spinal canal or the psoas compartment, it may be catastrophic. Neuraxial, so they decided that to call the neuraxial anesthetic intervention as a high-risk procedure, not in the term of blood loss, but in the terms of neurological deficits. Just to know that 5 out of 33 patients had a permanent neurological deficits in the last 3 years. So it is therefore recommended that a complete return of a normal hemostasis is required before any neuraxial deep plexus peripheral block is recommended to be done. The actual incidence of a neurological dysfunction resulting from the hemorrhagic complication associated with the neuraxial anesthesia is unknown. In the era before the routine use of perioperative thromboprophylaxis, it was estimated to be less than 1 in 150 epidural, 100,000 epidural, and less than 1 in 100,000 spinal anesthesia. This is previously, before the routine use of perioperative thromboprophylaxis. However, case series epidemiological survey suggests that risk has increased to become 1 in 3,000, especially in certain population, such as old lady going total knee replacement under epidural anesthesia. Okay, this is very important study by Mon et al., who investigated a series of neurological complications over 10 years. Among the spinal and epidurals block in Sweden. So, what is the finding? 33 spinal hematomas reported, 24 of which in the last 5 years. Okay. Among these 33 hematomas, 24 in the females. Okay. 25 associated with the epidural technique. Only 11 of these patients will have hemostasis abnormality, elevated liver enzyme and low platelet count and hemolysis. Only 11. 6 associated with the pathology of the spine. Okay. At the end, only 5 of these 33 patients recovered neurologically. Only 5, due to the delay in the diagnosis and intervention. What is the risk factor for developing epidural hematoma? There is antithrombotic, there is a patient-specific and procedure-specific. Patient-specific, that patient going under antithrombotic, old age, coagulopathy, renal disease, while the procedure-specific is a neuraxial block associated with a traumatic needle placement, difficulty with the block, and the use of indwelling catheters. All these represent a risk factor for developing hematoma. For example, the risk associated with the epidural anesthesia in women undergoing childbirth is much less than the risk of elderly women undergoing knee replacement. Also, when women undergoing hip fracture, they found that these certain population had higher risk to developing spinal hematoma than compared to the old patient undergoing spinal anesthesia in general. Okay, so I will discuss the recommendation guidelines for every type of every class of the antithrombotic medication. Now I will start with a direct oral anticoagulant. Why I'm starting with a direct oral anticoagulant? Because it is nowadays, it is the most commonly used anticoagulant. They act as oral direct factor 10 antagonist, like apixaban, endoxaban, and rivaroxaban, while dabigatran is a direct antithrombin inhibitor. Direct thrombin inhibitor, sorry. Just to know that at the time of publication of these guidelines, 4 months ago, there was no any associated spinal or epidural hematoma associated with the direct oral anticoagulant. The only hematomas that reported are either spontaneously or traumatic, but not associated with the anesthesia. The guidelines that are published in the ASRA 2025 mostly dependent on the pharmacokinetic properties and the expert opinion. Okay, because there is no randomized controlled trials that shows the association of spinal hematoma and direct oral anticoagulant. In general, in healthy patients who are young or old, a low dose, just to remember it, general rule, a low dose of direct oral anticoagulant, the time interval should be 2 half-life, while in high dose, the time interval should be 5 half-life, okay? Still, there is a risk of depending on only half-life because of the individual variability, which is become more important when high dose are used. So that they using a customized clothing test to determine the residual anticoagulant activity. Okay. Not only on half-life based calculation. Most experts and interventional anesthesiologists consider the plasma level of direct oral anticoagulant less than 30 nanogram per milli as a safe hemostatic threshold to avoid bleeding. So, for the management of neuraxial block or deep plexus block for a patient going oral high doses of apixaban, or endoxaban, or rivaroxaban, the recommendation say that it should be discontinued 72 hours prior to the neuraxial or deep plexus block, prior to the block. And when you have to do it less than 72 hours, you should have the checking direct oral anticoagulant level, okay? If it is less, or is checking the the factor 10 level. When the plasma level of the direct oral anticoagulant less than 30 and the plasma level of AXA activity less than 0.1, so you can do the neuraxial block. This is for high dose of this medication. Okay. When to resume the medication after spinal anesthesia, after high dose, it is usually 24 hours. So so the block should be done after 72 hours, and resumption of the medication should be done after 24 hours in the post-op. For low dose of apixaban, the time interval should be 36 hours. The low dose of rivaroxaban, the time interval should be 24 hours. Okay, if the creatinine clearance is if creatinine clearance less than 30, should be 30 hours. For low dose of this medication, the needle replacement should after at least 6 hours. The resumption of the drug after needle replacement should be after 6 hours. We have an issue with the drug, which is a part of the direct oral anticoagulant. It is the dabigatran. The dabigatran is totally dependent on the creatinine clearance. So when the creatinine clearance more or equal to 50 milli per minute, the time interval of discontinuation of dabigatran is at least 72 hours. But when the creatinine clearance 30 to 49 milli per minute, So we should wait for 120 hours. I think this is the longest time waiting for oral anticoagulant. And this is important also, when the creatinine clearance less than 30 milli per minute, we should not do against they suggest against the performance of the neuraxial or deep plexus peripheral blocks. This is for high dose. For low dose, dabigatran, also it is dependent on the creatinine clearance, but the time interval now it is 48 hours. And also when the creatinine clearance less than 30, they don't suggest the performance of a neuraxial or deep plexus blocks. Another issue is the reversal of the direct oral anticoagulant. Actually, ASRA do not recommend against the use of direct anticoagulant antidote to facilitate the placement of a neuraxial or deep peripheral block. I will discuss the unfractionated heparin briefly because there is no change in the recommendation from the already known previous recommendation. They just recommend something. The patient record should be daily reviewed to determine the concomitant use of medication that affect the other pathway of hemostasis. And any patient who is receiving intravenous or subcutaneous heparin more than 4 days, we should have platelet count assessed. So, for IV heparin and subcutaneous heparin should be stopped 4 to 6 hours before the block. This is for low doses heparin. Low doses, that means 5,000 to 10,000. Should be so. The time interval should be 4 to 6 hours. But for sub-Q and IV, for sub-Q heparin with a high dose per day, more than 12 hours should be, the time interval should be more than 12 hours to confirm the coagulation. But if the heparin was more than 20,000 per day, so the block should be done more than 24 hours to confirm the coagulation. For post-op first dose should be 1 hour for low doses intravenous and subcutaneous heparin. Low molecular weight heparin. You know that the low molecular weight heparin is the most used beside the direct oral anticoagulant. The most prevalent are the lack of monitoring required. Why they are using these? Because of the lack of monitoring required, a prolonged half-life, and inability to reverse with the protamine. They cause the AXA level peak after 3 to 5 hours after administration. Elimination half-life of low molecular weight is usually 5 hours after subcutaneous, and the elimination half-life is prolonged in cases with a renal failure. For the first 5 years of use, more than 40 spinal hematomas were reported, and the risk of the spinal hematoma was to be estimated 1 in every 3,000 continuous epidural anesthetic, compared to the 1 in 40,000 spinal anesthesia. Age and gender are significant patient risk factor. Because of the maybe smaller vertebral compliance, and the drug effect, maybe exaggerated response to the low molecular weight and renal insufficiency. We should differentiate it from low dose to the high dose. So low dose, low molecular weight heparin is enoxaparin, 40 milligram per day or 30 milligram every 12 hours. while high dose prophylaxis it is already dependent on the weight. Enoxaparin 1 milligram per kilo every 12 hours or 1.5 milligram daily. So this is very important to differentiate low and high dose low molecular weight heparin, because the management is depend on the doses. For pre-op low molecular weight heparin, low dose should be the needle placement more than 12 hours. Okay, preoperative high dose should be more than 24 hours. I think everybody know that, no change in the recommendation. The new issue is with the low molecular weight heparin is the measurement of the platelets, because just like heparin, that might treatment more than 4 days might cause thrombocytopenia. The resumption of post-op low molecular heparin, low dose PID more than 12 hours, single dose daily more than 12 hours, but the second dose should be done after 24 hours. But in the post-op therapeutic dosing, which is a high dose, resume low molecular weight 24 hours. According to the risk of the surgery, if it is low risk 24 hours, if it is high risk 48 to 72 hours. That's great. I have a lot of medication to talk about, but I will talk about
Only 1 minute.
only 1 minute.
Yes.
خلاص the new agent, which is the parental anti-factor 10 agent, the Fondaparinux. This is a new agent used in the critically ill patient, acutely ill patient, and patient with a cancer or patient undergoing a surgery. The dose is 2.5 low dose, and high dose is 5 to 10 milligram. I will not go into just to take, I think every other medication have the same recommendation or guidelines, we know. Just to take home message that when performing any regional anesthesia in patient on blood thinners, timing is everything. Okay, thank you very much.
Thank you, Dr. Amina. Next speaker, Dr. Abdurrahman Al-Hazmi. He will talk about preoperative care of older adults scheduled for inpatient surgery. And Dr. Abdurrahman is a consultant anesthesia and pain management. He holds the European Board, Saudi Board, and Arab Board in anesthesia and intensive care. He completed a pain management fellowship in Italy and fellowship in development education and equality from George Washington University. Welcome, Dr. Abdurrahman.
هنا يمين وشمال. انت لو كاتب نوتس هتطلع لك
يمين وشمال.
هنا كده بس كده.
ما نقدر نكبرها اكبر من كده.
لا ما عشان ده علشان ما توصل على اكسترنال بس الشاشه بتاعتك هم مش بس وراك.
اوكي. My name is Abdurrahman Abdul Fattah. I am an anesthesia consultant and pain consultant. I am talking about guideline 2025. This guideline, it is talking about older people during anesthesia as inpatient. Okay, this guideline is collected from multiple study which focus on this problem, and this guideline aims to minimize the risk for elder people from prolongation or prolonged hospital stay, increase mortality, loss of some patients lose their independent, become independent after the surgery. So that this study is focus how to avoid all that problem. Challenging in the patient, there is specific challenging, which is delirium, post-operative delirium. It is temporary change for elder people, and there is long-term effect from anesthesia on older people, which is affecting cognitive function. And third thing is complication from anesthesia, especially deep anesthesia, which is linked for delirium or other side effect like disability. Okay, to avoid all that problem, this guideline summarize some solution. One of the solution, it is extend preoperative evaluation, which include cognitive assessment and assessment for virality, and also if the patient have high risk, can use multiple team like nutritional. Also we can start rehab of the elder patient before the surgery to minimize all the risk factor the risk can be happen for the elder people. Other solution which is talk about the type of anesthesia. In general, I try to summarize all that guideline. General anesthesia or neuraxial anesthesia, it is no different between these two types. You can choose or modify your type of anesthesia according to the patient situation or need. Regarding to light anesthesia is preferred, and you need to monitor the depth of anesthesia for your patient. According to delirium, dexmedetomidine can get a good effect and can reduce the delirium and reduce the side effect and the stay of the patient or other side effect of the patient, elder patient. But dexmedetomidine, you need to monitor the side effect like bradycardia and hypotension. Third solution, post-operative, which is a target to decrease or minimize the medication that affect cognitive or that affect can lead to delirium, like use strong opioid or midazolam, antipsychotic. We can use it, but we can use it in caution. Also monitor the patient for early detection of delirium or confusion and manage it. Also rehab supposed to be initiated early. Key recommendation. First thing, the first recommendation, expand evaluation to reduce delirium risk. Second thing, general or neuraxial anesthesia, or both of this type is acceptable according to the patient case. IV or inhalational anesthesia, both acceptable also according to the patient need. Dexmedetomidine can be used to reduce delirium with caution. A strong opioid or the medication that affects CNS system can be used with caution. Gaps in that articles or that study that refuse. There is unclear link between anesthesia depth and delirium. It needs to be more studies. No optimal dose or timing for the dose of dexmedetomidine. Just only give general recommendation. Need more high quality study on delirium prevention. Also, it need more studies. Conclusion, comprehensive preoperative assessment is essential. Light anesthesia and individual and specialized or special care anesthesia for each patient. Okay, more research is needed to cover some gaps. Thank you very much. I make it a light lecture because at the end of the day. Thank you for listening.
Thank you. It's open for questions.
Thank you very much for your fruitful lectures today. My first question, Dr. Mustafa, regarding dexmedetomidine. dexmedetomidine, until now there's 14 different drugs were tried as an additive to local anesthesia. Only 3 of them are, one of them is proved that it's very effective, which is epinephrine, and the other 2 are promising, which are the dexmedetomidine and dexamethasone. My question, there was a side talk during your lecture with, we know, everybody knows that one of our sponsors here is the book company, and they have a product of dexmedetomidine among their products. I asked if actually the agent of this company is the dexmedetomidine, which you produce is a preservative-free. He told me yes, it's a preservative-free. Then next question, the other products in the market are preservative-free. He told me he don't know, but he thinks some of the other products, it's not a confirmed information, is a preservative-free. How we know the drug which we are using is a preservative-free or not? Because maybe after this lecture, one of the attendants here, he said, okay, I will use a 10 mics in the spinal, and he used a product which is not known, is it a preservative-free or not a preservative-free, and what serious complications could happen after this. Second, regarding the same topic, second question is, when I'm on my personal practice, because I'm a regional anesthetist and I'm adding dexmedetomidine to my blocks, and I'm adding, of course, a higher much dose, giving 50 or 100 mics for regional blocks. I'm seeing sometimes for my patients some side effects like bradycardia, like hypertension. How these side effects are seen in patients when it's given intrathecally?
Thank you very much. Regarding the first question, which is about is it preservative-free or not? It depends according to the company. For example, you mentioned that the tobacco company is preservative-free. Before I conduct my study, I contacted the Hospera company at that time. They were producing the dexmedetomidine, and it was preservative-free. And I checked also in the leaflet, it is preservative-free. For other companies that produce the dex, we need to check before giving any medication. As we know, there is a risk if it is not preservative-free to have a harm in the neuron or in the central nervous system. So what I used during this time, it was preservative, which is very important. Regarding the second question, again,
the cardiovascular effects.
Yeah, the cardiovascular effect. As I mentioned in the lecture, we use a small dose, 5 and 10 mic a total, which added to the local anesthetic agent. When we increase this to 15 and 20, they increase in another study, they notice there is a side effect once used in the intrathecal. For sure, if we use this in the peripheral nerve block, we need more dose. As you mentioned, sometimes you use a 50 or 100 mic, which is large dose. So we need to take a precaution to treat this bradycardia or hypertension. And even when we use intravenously, honestly, for my patient, I mentioned in the lecture that we follow our patient during the surgery and 1 hour in recovery. I noticed that they call me in the evening regarding those patients that your patient still bradycardia. So the effect of dex is prolonged, and especially in old ages, and it takes time to back to normal. So 100 mic once used in the peripheral nerve block, for sure you will face a bradycardia and hypotension, and you should treat this and observe your patient for longer.
My second question is for Dr. Sam. And this is not only for you, for the attendants. How many of our colleagues here are using neuromuscular monitor? Because there is a push for using a deep neuromuscular block in all our, in at least in laparoscopic cases, and there is no push on monitoring these patients. Personally, I'm using, and Dr. Mona, she's using the same technique because we are colleagues in the same place. he's using neuromuscular technique, but I don't remember from our other colleagues using neuromuscular monitors. So sending a message of deep neuromuscular blocking without a message of making a neuromuscular monitors mandatory or a basic monitor to the patient, I think this may affect the results or the outcome.
Yeah, that's a very important to highlight. And as mentioned, and as was a statistic questionnaire which was made earlier in the 15 years ago among the anesthetists worldwide in US and Europe, we noticed that there is a very poor usage of neuromuscular monitoring everywhere. Having said that, now to provide efficient surgical workspace, and when we say we are going to put the patient into deep block, how can we tell he is deeply blocked if we are not monitoring? You cannot tell. You just keep giving those, and you don't know how the block depths. Patients differ in the response because of lots of factors, and I believe it's time that it is not a mandatory monitoring. But if we are going to put the patient, give him a high dose of neuromuscular relaxant and put him in a deep or profound intense block, this is definitely indicated. Finally, I think the hospital policy or the department policy, when some local studies or a retrospective analysis can be made over a year or so to check the length of stay or the percentage of post-op pulmonary complication for patients, and we can easily compare, and this will make the analysis find it beneficial to use. It will cost nothing if it is there. Why not to put it?
My last question to Dr. Mona. Dr. Mona, I've noticed in these guidelines there is some deficiency regarding mentioning in patients who are post-traumatic or post-lower limb fractures or lower limb orthopedic surgeries who had epidurals. I didn't notice that there is a mention about when to resume the anticoagulants after removal of the catheters. Because have you seen?
Yes. No, sorry. There is a recommendation for the removal, the timing of removal of epidural. After each type of anticoagulant, there is a certain time interval, so you can remove the epidural catheter. I mentioned after the direct oral anticoagulant, it should be 24 hours. This is according to the type and the dose. If it is low dose or high dose of direct oral anticoagulant, and the dabigatran.
With a clopidogrel, I was searching for clopidogrel. Clopidogrel
should be removed after 6 hours. So you put an epidural catheter, and you want to start clopidogrel. Actually, you can start clopidogrel for 1 to 2 days because the peak effect of clopidogrel needs 1 to 2 days. But you should stop clopidogrel at least for 6 hours before the removal of the catheter.
When to resume?
When
to resume, yes. My
on
patient clopidogrel.
You can resume clopidogrel 1 to 2 days. I want to resume clopidogrel after?
Yes. My patient, after surgery,
6 hours.
I removed the catheter.
6 hours.
Okay, when I can put him back on MI or
clopidogrel 6 hours. Because clopidogrel needs time to reach a maximum dose. It needs 1 to 2 hours to reach the peak effect. So you can start after 6 hours clopidogrel. But that's not applied to parasurgeon, let's say, because the peak effect is direct acting. It is rapid acting, so you cannot start parasurgeon, and you cannot give a loading dose of clopidogrel or parasurgeon after epidural. Okay.
It's a quick question for Dr. Mona. After how many days can you do after how many days can you do a spinal after stopping clopidogrel in trauma patients or emergency cases? This is the question. Because I think generally people are starting to push the boundary.
Yes,
and
this
not
is
put 7 days.
5 to 7 days.
For emergencies, 5
Yes,
days.
yes, 5 to 7 days.
Okay.
They mentioned the 5 or 7 days.
Dr. Mahmoud, regarding using dexmedetomidine intrathecally, is it, as far as I know, it is not FDA approved, even Saudi FDA. How do you feel comfortable to use it?
There's always argument regarding this point. It is not FDA approved, but there is thousands of research, RCT, regarding this issue. Fentanyl also is not FDA approved. All of us use the fentanyl. So the same issue. There is a lot of clinical trials, thousands, and let us say it is used off-label. It is used. But from inside, once we use it, we feel not relaxed.
Do you think that using of Silomedex decrease the necessity of monitoring the neuromuscular?
Well, using Silomedex decrease the need for neuromuscular block.